Hello everyone, I am Afreen and welcome to today's lecture. Today my topic is going to be about cancer and diabetes. My topic will be covering the following objectives: cancer and its prevalence, the role of psychology in cancer, the psychosocial factors in the initiation and promotion of cancer, interventions, therapies with cancer patients, diabetes, main types of diabetes, health implications of diabetes, psychosocial factors in the development of diabetes, stress and diabetes, the management of diabetes, diabetes prevention, type 1 diabetes, managing type 1 diabetes, special problems of adolescent diabetics, and relations with family. So let us start with cancer and its prevalence. Cancer is a set of more than 100 diseases that have several factors in common. All malignancies are caused by a malfunction in the DNA, which is the component of cellular programming that regulates cell growth and reproduction. This dysfunctional DNA leads to abnormally quick cell development and proliferation rather than assuring the regular, slow generation of new cells. Cancerous cells don't benefit the body like normal cells do. They simply drain it of its resources. Cancer is characterized by unchecked abnormal cell production that results in tumors known as neoplasms. There are two sorts of tumors: benign tumors, which do not metastasize outside of the body, and malignant tumors, the process of cells breaking off from the tumor and moving elsewhere. There are three different forms of cancer cells: leukemias, which develop in the blood, sarcomas, which start in connective tissue, and carcinomas, which make up 90% of all cancer cells and start in tissue cells. Now we'll talk about the prevalence of cancer. In 2008, cancer accounted for 7.6 million deaths worldwide, around 13% of all deaths, and is now the leading cause of death. The main types of cancer are lung, 1.4 million deaths, stomach, 7,40,000 deaths, liver, 7 lakh deaths, colorectal, 6,10,000 deaths, and breast, 4,60,000 deaths. Deaths from cancer worldwide are projected to continue to rise to over 11 million in 2030. Because psychosocial factors are implicated in the development and progression of cancer, the health psychologist has an important role in addressing these issues. Interventions to lower risk factors and enhance coping with cancer are also crucial because it is a disease that individuals commonly live with for a long time. Numerous factors make studying cancer challenging. Each cancer has different causes, symptoms, and treatments. Numerous malignancies have prolonged or unpredictable growth cycles. Finding contributing or co-occurring risk factors may be challenging. Due in part to genetic causes, many cancers run in families. However, a family history of cancer does not always indicate a genetic predisposition to the disease. Cancer is generally more strongly linked to lifestyle than to genetics, since many things other than genes run in the families, including nutrition and other lifestyle factors. Some cancers are thought to be caused by infectious pathogens. For instance, Helicobacter pylori is thought to be responsible for some types of gastric cancer, while the human papillomavirus is the leading cause of cervical cancer. Ethnicity plays a role in several malignancies. Some malignancies have lifestyle-related cultural connections. For instance, Japanese American women are more likely to develop breast cancer the longer they have lived in the country and more American culture they have absorbed. It is assumed that dietary changes are responsible for this rise in vulnerability. Many malignancies are correlated with socioeconomic class, and those with low socioeconomic status are more vulnerable. Additionally linked to the development of cancer are dietary variables. People who are chronically undernourished and who consume large amounts of lipids, certain food additives, and alcohol are more likely to develop cancer. The interplay of risk factors that lead to specific malignancies is starting to receive more attention in research. For instance, women who are sedentary, overweight who eat a lot of starchy foods like potatoes and rice are more likely to develop pancreatic cancer. Let us now discuss the role of psychology in cancer. Gillen, who believed that melancholy cancer is associated, and Jidman, who hypothesized that cancer might be tied to life disasters, were the first to indicate that psychology may have a role in cancer. Additionally, it is believed that over 30% of cancer-related deaths could be avoided. Therefore, psychology has an impact on cancer in a variety of ways. First, psychological variables play a significant role in the development of cancer. Secondly, psychological factors play a role in screening, help seeking, delay, and adherence. Additionally, cancer patients describe psychological effects that may affect coping, adjustment, and quality of life. Not every cancer patient experiences the same rate of death progression. Perhaps psychology has a role to play in the progression of cancer. Not all cancer sufferers die of cancer. Perhaps psychology has a role to play in the longevity. Now we will be talking about the psychosocial factors in the initiation and promotion of cancer, and these are: the first one includes behavioral factors. According to study, up to 75% of all cancers are linked to behaviors including smoking, eating poorly, drinking too much alcohol, and engaging in sexual activity. Behavioral variables have been found to play a role in the development and spread of cancer. Individual health attitudes can be examined to predict these actions. Utilizing interventions for behavior modification, they can also be changed. Furthermore, early detection, help-seeking behavior, and symptom perception are all factors that can affect health outcomes. The second one is stress. It has been established that stress contributes to the development and spread of cancer. Stress following a diagnosis may also have an impact on whether or not a person alters their health-related behaviors for the better. The third one is life events. It has also been proposed that certain life experiences may contribute to cancer. The disparities in life events between families with a cancer victim and those without were explored in research by Jacobs and Charles. They found that people who had moved homes, people who had altered their behavior in some way, people who had experienced change in their health other than the cancer victim, and more people who had experienced divorces in families with a cancer victim, indicating that life events may very well be a factor contributing to the onset of cancer. However, the findings of a meta-analysis conducted by Petit-Crevetal refute this assertion. The fourth one is control. It has been suggested that having more control over environmental elements and stressors may be linked to an increase in the start of cancer. Control also appears to have a role in the development and promotion of cancer. The fifth one is coping styles. Coping mechanisms are also crucial. If a person experiences stress, the coping mechanisms they employ may very possibly be linked to the development of cancer. The sixth one is depression. Bilioscus highlighted a relationship between depression and cancer and suggested that chronic mild depression, but not clinical depression, may be related to cancer. The seventh one is personality. A few studies have looked into the connection between personality and cancer. According to Temushuk and Fox, people who had cancer have a type C personality, which is characterized as being emotionless, passive, accommodating, powerless, and other-focused. Eysenck coined the term a cancer-prone personality to characterize people who exhibit despair, hopelessness while under stress, and who suppress their emotional responses to traumatic experiences. An early study by Kissin confirmed this link between personality and cancer and found that people with lung cancer who smoke heavily had poorly developed emotional coping mechanisms, possibly pointing to type C personality. However, the relationship between cancer and personality is not a straightforward one. And the last psychosocial factor is hardiness, a coping strategy known as hardiness with three components: control, commitment, and challenge was defined by Kobasa et al. Low control may indicate a propensity to exhibit sentiments of helplessness while under stress. As opposite of alienation, commitment is defined as those who find purpose in their profession, values, and interpersonal relationships. People who thrive on challenge view potentially unpleasant situations as a task that must be overcome successfully. Hardiness may offer protection against cancer development. Let us move to another objective of my topic, which is interventions. Prior to treatment, educational interventions are vital. Cognitive behavioral therapies to issues related to cancer are frequently used during or after treatment, with an emphasis on depression, stress, exhaustion, pain, appetite management, and side effects related to chemotherapy, radiation therapy, and other cancer treatments. The quality of life can be considerably improved by these therapies. Interventions for stress reduction based on mindfulness are also promising. The main goal of interventions with cancer survivors is to improve health behaviors. Following cancer, exercise can enhance quality of life. Physical activity increased quality of life after cancer diagnosis, including a higher sense of self-efficacy, better physical functioning, and enhanced emotional well-being, according to some research. Although painkillers continue to be the mainstay of cancer-related pain management, behavioral approaches such as relaxation therapy, hypnosis, cognitive appraisal methods, visual imagery, and self-hypnosis can help. Fever symptoms and fever visits to the doctor for cancer-related issues have been linked to writing therapies involving expressive disclosure or writing on benefits obtained from cancer. Now let me bring your attention to another objective, which is therapies with cancer patients. The first one is cognitive behavioral therapy. When given a cancer diagnosis, some people engage in cognitive behavioral therapy interventions on their own, in groups, or online. These therapies frequently center on lowering depression, controlling stress, reducing recurrent dread, and acquiring effective coping mechanisms. Next one is family therapy. Family therapy is frequently used because it helps cancer patients receive emotional support from their loved ones. However, not all families are able to speak openly with one another. Psychological discomfort may rise when there is a mismatch between the social support that cancer patients need and want. Another one is support groups. Many cancer patients can find and benefit from self-help groups where they can share their emotional issues, especially those who have few other social or personal resources. Only a small portion of people, nevertheless, take advantage of the opportunities offered by support groups. Cancer sufferers now frequently utilize the internet to connect with other cancer patients for social support. And the last one is internet interventions. Opportunities to help cancer patients can be found online. Targeted coping mechanisms, mood-enhancing techniques, and social support are all possible. Now coming to another objective of my topic, which is diabetes. Diabetes, often known as diabetes mellitus, is a collection of metabolic illnesses in which a person has high blood glucose either as a result of insufficient insulin synthesis, as a result of improper insulin cell response, or as a result of both. Polyuria, frequent urination, and polydipsia, growing thirst and hunger, are common in patients with high blood sugar, which is also called polyphagia. The word diabetes is Greek in origin and means siphon. Diabenian was the term given to the ailment by the Greek physician Aratus the Cappadocian in the 2nd century AD. He compared patients who had polyuria, that is, excessive water passing, to a siphon. The name diabetes was created when English speakers adopted the medieval Latin term for the condition. Mellitus was first introduced to the phrase by Thomas Willis in 1675. Although it is commonly referred to simply as diabetes. Mel in Latin means honey. The urine and blood of people with diabetes has excess glucose, and glucose is sweet like honey. Diabetes mellitus could literally mean siphoning of sweet water. Diabetes is a long-term condition that causes high blood sugar levels. Over 382 million individuals worldwide were expected to have diabetes in 2013. Now coming to the main types of diabetes, which will cover another objective of my topic. The first very type of diabetes is type 2 diabetes. Either the cells in the body do not respond to insulin, or the body does not create enough insulin for normal activity, which is also known as insulin resistance. Around 90% of diabetes cases were type 2 instances worldwide. By decreasing weight, maintaining a nutritious diet, getting enough of exercise, and keeping an eye on their blood glucose levels, some people may be able to manage the symptoms of type 2 diabetes. But because type 2 diabetes is frequently a progressive condition that worsens over time, the patient will almost certainly need to take insulin, typically in the form of tablets. The causes of type 2 diabetes are now understood to a large extent. The complex balancing act of insulin synthesis and insulin response occurs during glucose metabolism. Carbohydrates are converted into glucose during digestion. Intake of glucose into the blood from the intestines transports it to the liver and other organs. The pancreas releases insulin into the bloodstream as blood glucose levels rise. Type 2 diabetes is triggered when this balance is out of whack. First, insulin resistance, a condition in which cells in muscle, fat, and the liver lose some of their capacity to completely respond to insulin, occurs. The pancreas briefly boosts its output of insulin in response to insulin resistance. At this stage, insulin-producing cells may stop functioning, causing a decrease in insulin production and an imbalance between insulin action and insulin secretion that leads to type 2 diabetes. Frequent infections of the skin, gums, or urinary system are common symptoms, as are frequent urination, weariness, dry mouth, impotence, irregular menstruation, loss of sensation, discomfort or cramping in the legs, foot or fingers, sluggish healing of wounds and bruises, extreme itching, and sleepiness. 90% of type 2 diabetics are overweight, and males and adults over 45 are more likely than women to have the disease. Type 2 diabetes is heavily a disorder of aging. About 26.9% of people aged 65 or older have diabetes, compared with 3.7 and 13.7 per among those aged 20 to 44 and 45 to 65 respectively. Now we'll be talking about health implications of diabetes. Due to the accumulation of waste products in the circulation, diabetes is linked to a hardening of the arteries. As a result, persons with diabetes have significant incidences of coronary heart disease. Nearly half of all patients who need renal dialysis due to kidney failure have diabetes, which is the main cause of blindness in adults. Damage to the neurological system, such as discomfort and a lack of sensation, can be a complication of diabetes. In severe cases, amputation of the extremities, such as the feet and toes, is necessary to prevent foot ulcers from developing. Diabetes raises the risk of developing vascular dementia and Alzheimer's disease. Because all of these issues, diabetics have a reduced life expectancy. Diabetes also causes psychological side effects such as problems with sexual function, an increased risk of depression, and memory-related cognitive dysfunction. Let us now discuss psychosocial factors in the development of diabetes. Obesity, poor diet, and insufficient exercise are all lifestyle variables that have been linked to the development of type 2 diabetes. Additionally included are personality traits. One contributing factor is low conscientiousness through poor weight control and physical inactivity. A further factor can be dysfunctional coping. Poor marital quality and job stress have both been linked to an increased risk. In part because of its connection to gaining weight, depression is also a risk factor. Positive mental health can prevent diabetes. Let us now talk about stress and diabetes. Stress can have a negative impact on people with type 2 diabetes. Diabetes may be exacerbated by high-risk individuals' abnormal glycemic responses to stress. After type 2 diabetes is identified, stress exacerbates the condition. Similar to how sympathetic nervous system reactivity contributes to the pathogenesis of type 2 diabetes and the development of coronary heart disease and hypertension. Moving to another objective of today's topic, which is the management of diabetes. Active self-management is essential for effective diabetes management. High-risk persons can fully avoid type 2 diabetes by altering their lifestyle. Exercise, stress reduction, weight loss among overweight people, and nutritional control are all advocated. Dietary intervention includes consuming fewer carbohydrates and sugars. Patients are urged to reach a normal weight since obesity appears to strain the insulin system particularly. Exercise is particularly important because it aids with weight loss and uses up blood glucose. Education is undoubtedly a crucial part of intervention. Adherence depends on several more factors. Because they stick more closely to a treatment plan, those with strong self-control abilities perform better in terms of glycemic control. Another crucial factor is the conviction that diabetes can be managed. Social support typically increases adherence, but this is not in the case for diabetes. Social interaction might result in food cravings that impair the functioning of diabetics. With type 2 diabetics, cognitive behavioral therapies have been used to enhance adherence to certain components of their regimen. Programs have also emphasized teaching patients how to appropriately manage their blood sugar levels. Depression interferes with diabetes patients' ability to actively control their condition and impairs the prognosis. Therapeutic methods, therefore, also concentrate on these emotional effects. Due to the links between stress and diabetes, behavioral researchers have looked at how stress management programs affect the treatment of diabetes. Training in self-management and problem-solving skills is a vital part of many interventions with diabetes. Because of problems involving adherence, a focus on maintenance and relapse prevention is also essential. Let us now discuss diabetes prevention. Health psychologists and policymakers are increasingly putting a focus on prevention because diabetes is such a significant and expanding public health issue. Researchers are continually looking for the most efficient and affordable ways to teach self-management skills to patient groups, as is the case for other chronic diseases, and this is true for type 2 diabetes patients as well. Smartphones have been used to measure adherence, and internet-based diabetic self-management tools may be the wave of the future. Let us discuss another type of diabetes, which is type 1 diabetes. The symptoms of type 1 diabetes, which is an autoimmune condition, appear suddenly and are brought on by the beta cells in the pancreas' inability to produce insulin. The condition may manifest after a viral infection and most likely has a hereditary component. According to Lehman, Rodin, McQueen, and Brinton, stress can cause type 1 diabetes in people who are genetically predisposed to the condition. Rates of this condition are also rising, increasing from 24 to 27 per lakh people between 2002 and 2009. In type 1 diabetes, the immune system mistakes pancreatic cells for foreign invaders and attacks them, reducing or eradicating their capacity to make insulin. Girls are more likely than boys to develop type 1 diabetes early in childhood. The disease typically appears between the ages of 5 and 6 or between 10 and 13 years old. Frequent urination, unusual thirst, drinking too much fluid, weight loss, weakness, irritability, nausea, and insatiable need for food, particularly sweets, and fainting are the most typical early symptoms. These symptoms are brought on by the body's search for energy sources, which causes it to consume its own proteins and fats. If the problem is left untreated, a coma may develop as a result of the byproducts of these lipids building up in the body and causing symptoms. 1 in 10 cases of diabetes are type 1 diabetes, a serious, life-threatening condition. It is primarily treated with insulin injections directly into the body, hence the name insulin-dependent diabetes. The type 1 diabetic is more susceptible to hyperglycemia or high blood sugar, which can cause a coma and even death if untreated. At least 15 studies have reported direct links between stress and poor diabetic control. Now, we'll talk about managing type 1 diabetes. Patients with type 1 diabetes need to monitor their glucose levels throughout the day and take prompt action when necessary, since very tight management of glucose levels can significantly alter the course of this disease. Success in the management of the condition depends on the patient's active participation as a co-manager. Regular insulin injections, dietary restriction, weight control, and exercise are typical components of this therapy. Each day, a certain number of calories must be consumed. A meal plan must be used to regulate food intake rather than temptation or hunger. Management of diabetes also demands adherence. Unfortunately, it seems like few people follow self-management programs. In general, just 15% of patients seem to follow all of their therapy recommendations. These hazards do not scare individuals into adhering because many of the serious effects of diabetes do not become apparent until 15 to 20 years after its onset. They could not experience any symptoms, failing to follow their treatment plan as a result. When patients employ active coping techniques as opposed to passive or avoidant ones, they are better able to manage their condition and their diabetic regimen. When patients and their doctors discuss treatment goals, adherence improves. Coming to another objective of my topic, which is special problems of adolescent diabetics. Diabetes control is a specific issue for teenagers. They are intertwined with concerns about independence and a growing sense of self, and diabetes and the limitations it imposes conflict with these developmental goals. The typical pressures of adolescents worsen metabolic regulation. Teenagers could see their parents' dietary restrictions as attempts to discipline them. People who are different are frequently ostracized within the peer culture of adolescents. In order to avoid being rejected, the teenage diabetic may forego necessary care. Adolescents who can learn from their experiences and are emotionally stable and conscientious are more likely to adhere to the strict routine that diabetes demands. Stress and depression jeopardize effective self-care. Now, let us move forward to the last objective of today's lecture, which is relations with family. The proper management of the treatment plan depends heavily on the parents. However, they could respond in ways that jeopardize managerial initiatives. Adolescent diabetics may be treated like children by their parents, who may restrict their activities beyond what is necessary, infantilizing them and making them more dependent. Instead, the parents might make an effort to persuade the child that he or she is normal. Unfortunately, family strife and inadequate parental supervision are risk factors for poor glycemic control and self-care. The efficacy of treatment and medical care may be hampered by a parent's own issues, such as depression. By figuring out the most effective ways to explain the challenging treatment plan, health psychologists can play a significant role in the management of type 1 diabetes. That brings us to the end of the topic. Thanks for watching.